wanted to give you a few more tidbits because there's a few more slides we didn't get to today related to spinal cord injuries. I know we talked a little bit about airway, breathing, circulation, and oxygenation already. In addition to that, when you're doing an initial assessment on these patients, look for signs of hemorrhage. That might be bruising, it might be swelling of the abdominal cavity, it might be some bleeding around any fractured areas of the body. Because hemorrhage can have a key impact, of course, on circulation as well. So you're trying to make sure what would be causing a low blood pressure, is it more than one thing? Additionally, we of course are going to do a Glasgow Coma Scale so we can compare is this person having any deficits, and or as a baseline, how is that tracking in terms of ongoing ability to stay conscious. Level of injury, I already talked a little bit about how you would assess that. Most of the time people are going to take some kind of a little object that they can test and move up and down the body till they can find kind of the level of paralysis, which is your plegia. Or in some patients, they may look for just a tingling sensation. It's not that they're paralyzed, but they have some numbness and tingling at a certain point so that that maybe there's not complete paralysis, but there is still some effect that is going on to the nerves at certain levels in the body. So with respiratory, what do you expect to find? Patients can be having lack of respirations because they totally have no diaphragmatic control. They can have very shallow kind of respirations where they're mostly just moving the upper airway. They could have rapid respirations or periods of apnea. So it's really important to look at all those, and putting them on a monitoring system for oxygenation is extremely key early on, because ultimately that's going to tell you how well, irregardless of what's going on with their respiratory patterns or airway, that's going to let you know whether any of that's effective in terms of oxygenation. And it also is an ongoing way to measure and know that, if you do end up having to intubate a patient, which might be done if there's a crisis with their breathing difficulty, you're going to need that because you have to make sure that ongoingly they're being monitored throughout that whole process and ongoing if they're put on a ventilator. Again, what actions might be needed to support respiratory function? You may end up having to suction the patient. You may end up having to bag the airway of the patient. And the endotracheal tube that I mentioned in class has a bulb on the end of it. And I'll try to send you guys some pictures to go along with this recording. But those have a bulb on the end that gets blown up, and it can cause a corrosive effect to the inside of the trachea over the long haul. So ideally, you would also, down within a week or two, within 7 to 14 days, if someone is going to be ventilator dependent because of this ongoing paralysis that's not going to resolve, then it is very important that doctors go ahead and talk with the family about doing a tracheostomy, which is a more permanent airway without the need for a cuff that's used and exerted pressure against the trachea, thus prolonging the integrity of the trachea for the person for the long haul. And so there's lots and lots of things that you'll see more as you get into critical care related to that. So in terms of cardiac assessment, we already talked about the potential for bradycardia. We talked about hypotension because of the loss of vasomotor tone and pooling of blood. And, what values would concern you. You want this person to have sort of a normal blood pressure. So something below 90/50 would be a little bit concerning to me as a general rule, but each institution or each unit that deals with this disease might have some set alarm parameters to be aware of. In terms of hypertension treatment, that might consist of giving what I talked about in class with pressor agents like dopamine, Levophed, dobutamine, all of which you'll get more on in critical care, so you don't have to commit that to memory now. But also, you may be asked to give fluid boluses just to bring the volume up, and that sometimes will help the blood pressure as well. So you want to be watching any of this when you're giving extra fluids with how well are they tolerating some of that on the respiratory side too. You also may have a patient develop hypertension, and again, that might be related to autonomic dysreflexia, and I'm going to talk about that slide very soon. And sometimes patients can have hypothermia or hyperthermia, so look that up and kind of be aware of what might be at the cause of that. Again, we talked about this slide in class, but I wanted to reiterate it because it is a very common thing, not just for an initial injury, spinal injury, but for patients that live with paraplegia or tetraplegia. They can have this happen, and it can be a potentially life-threatening condition, so that's why you really need to take this seriously. And it happens because of some kind of noxious, visceral, or cutaneous stimuli. So what does that mean? That means that something in their viscera is creating a pain sensation, a stimulation, or on the skin, there is some kind of stimulus that is making the patient have this uninhibited reflex sympathetic discharge. So, suddenly their sympathetic system is gone haywire. And it may be something as simple as their skin is laying on something that was left in the bed. Now, the patient can't tell you that because they don't feel it, but it's still a cutaneous stimuli that can create this kind of life-threatening condition. So it's important really to just be a great investigator when you see a high blood pressure with one of these patients. You might see some bradycardia. You go in and you look at them, they might be sweating or flushing. In your brain, you should be thinking, oh, it's the sympathetic nervous system. You might see a pale skin below the level of where their normal function is or feeling is in terms of their paraplegia or quadriplegia. Sometimes goosebumps may be above the level of lesion. The patients may complain of blurred vision or a throbbing headache, and quite often they have this look of apprehension that goes along with this and might even voice that to you. So because of the hypertensive crisis, as I mentioned in class, you are going to go ahead and immediately sit the patient up. That's your very first action. And then become the investigator and look for any kind of causal factors. You can go ahead and page the doctor in the meantime. While you're waiting for them to call back, you're going to really be looking for causes. So, as I said in class, urinary cause, is their bladder distended? Do you see any kinks in their urinary catheter if they have one? Does it look like there's any clumps or sediment in there that could be causing a blockage, or a blood clot in there that could be causing a blockage? Is it cloudy? Is their urine cloudy? Does it look like maybe they could have a UTI? They can just simply have a UTI and have this reaction. They could have a kidney stone and have this reaction. So the first action to really consider after trying to determine those things is catheterize the patient. If there's any chance that that it's retention, solve that problem. The same thing is true for the bowel. They can have fecal impaction or some kind of other colorectal irritation. And so something as simple as putting an anesthetic ointment to the rectum could create that sensation, and they can't tell you that, but they still might have that. So you need to check them for disimpaction. You should get a doctor's order for that. Most institutions require that because they want to make sure that a nurse is covered in doing that, because occasionally you could have somebody have a worse issue with their rectum from attempting that. But disimpact them if you need to. Something as simple as a new or a worsening pressure or ulcer or a skin problem somewhere can cause autonomic dysreflexia. So looking at everything you can think of that could be causing some kind of a stimulus is the best way to go about it. And it kind of in this order is a good way to think about it. You're going to monitor their blood pressure every 10 to 15 minutes. You may sit them up, you might catheterize them and check their blood pressure, and it's completely back down to normal. So you may not need medications. It can be a hypertensive emergency until you find out what the cause is. Sometimes they will give nifedipine, or another name for that drug is Procardia, or a nitrate drug. They also might order some alpha blocker drug prophylactically to kind of keep them from having a recurrent issue with it. But those are some of the treatment, and just knowing as a nurse, many times we can solve this without even having medications or orders, but the actions that we would do. Other symptoms, and I'll run through these quickly. GI assessment findings, with a spinal cord injury, you look for all of these kinds of things. Over time, they can have a paralytic ileus, they can get impacted, they can have severe constipation. Watching their diet and their nutrition is a big issue because, many of them may be on tube feedings if they're unable to swallow. Some of those can be constipating, and so making sure that they get the support for all that to keep everything moving well and absorbing well is good. They may have glucose levels being checked like every 6 hours because of the effect of the tube feedings. It could be also ordered because they're on corticosteroids sometimes for inflammation. And so those kind of things might be typical orders that you would see. Often they're going to have problems with swallowing, and speech therapy is consulted to work with them on that. And we do have to do strict I&Os on these patients. These are just, again, to reiterate some of the things about the bladder function. For the best teaching for your patients, I would put you to look at the Paralyzed Veterans of American website. They have some very nice bladder and bowel programs that you can use as teaching for your patients. In terms of drug therapy, this is just to name a few that you might come in contact with for these patients, and the reasons why they may be given. Surgical management, again, just like we saw before, if they can stabilize the column, they will try to do that within 24 hours, get out bone fragments, any hematomas, any penetrating objects. They may do a spinal fusion, they may have rods, they may have wiring. They may have to have a hard C-collar or a TSLO brace to kind of keep everything stable after surgery. And again, for any kinds of braces like that, you're going to watch the skin around those areas. Those are your key priority areas that we've already talked about. There's a video here that you can watch related to really how to respiratory support and